All right. Can everybody hear me okay on the phone? Cool. Good talk. All right. So a couple of things. I don't know why I grabbed that. A couple of things that I want to cover since we're on the topic. As far as these monthly trainings go, there's a handful of people that just took this instructor class. If you're not working here, I don't know. Is Ursula an instructor?
She logged off anyway.
So if you know an instructor that needs hours and wants to do something super cool in these monthly meetings, let us know. If there's something that you want to do, that's also cool. Just let us know. Outside of that, if there's any one particular thing that you want to go over, also let us know, because we can kind of cater a lot of this stuff basically around whatever we want to, and we can kind of word it, how we need to through the state to get CEUs out of it. But I know Hannah's brought up the drip thing before. If there's anything in particular, I think a good idea would probably be to start some sort of like training log, and just have people put suggestions in there as far as what we do in these monthly meetings, just so we can kind of build some trainings around stuff that people actually want to go over and actually want to learn about. Second thing about that cardiac arrest, just a quick overview of that. We're going to do a handful of trainings, but just to try to get everybody on the same page. And essentially what we talked about is, it's one of those high acuity, low frequency calls, right? People don't run them all the time. And it's not something that we deal with a lot, especially being out here. But if we could get everybody, especially because we're a small department, if we could get everybody running these cardiac arrests the same, then if y'all two get a cardiac arrest tonight and me and Becca show up second in, we already know what y'all are doing. That way we know how we can help, right? And so essentially what we're going to do is focus initially when you come off the truck with just a Lucas and just oxygen. And so we're going to put pads in the Lucas machine in the bag. And so when you come off the truck, the first thing you're going to do is walk inside of a house, put pads on a patient, put Lucas on a patient, put them on nasal cannula, passive oxygenation, high flow, open wide open. And so basically what you're doing is, Becca likes to say, is you're priming the pump. You let them sit on that Lucas for 5 minutes and you don't touch them for 5 minutes. I mean, you can do IOs and stuff like that, but you do not stop that Lucas for the first 5 minutes, right? So after you go in and you put the Lucas on, if you're the only one still there, which most of the time you're not going to be, but if you are the only one still there, you'll go back out to the truck at that point, put all your stuff on the stretcher, your jump bag, your meds, whatever you need. And you'll take that stuff, suction, you'll take all that stuff back in the house. And that way, by the time you get back in the house, you can get an IO in them, your 5 minutes is up, and then you can start working the arrest like you normally would. And essentially what it does, right, is so like if y'all two show up to an arrest first and y'all jump off the truck with Lucas and oxygen, and then me and Becca pull up to that same arrest and we look in the back of that truck, we know what y'all have inside, and so we can grab everything that you don't have. Right, so it gets everybody working the same, but statistically, cardiac arrests are safe by good CPR and early defibrillation, right? So people get hung up on focusing on epi and intubation and all this other crap, and they forget just doing good quality CPR and early defibrillation is what saves these folks, not drowning them in epi and vasoconstricting them to the point that they're brain dead. So yeah, we're going to work through that. It'll be something that we do with everybody until everybody feels super comfy with it. And then hopefully we can get everybody on the same page. I know we were doing it in Georgia, and we had at the service that I was working for that did implement cardiac arrest like that, they had one of the highest ROS grades in the state, and they wouldn't use more than like 3 EPIs on any cardiac arrest. They were hanging levo on PEA arrest, but they also had very, very, very high ROS rates. So that was pretty cool. So we're going to implement that. And then, like I said, if y'all have suggestions as far as training goes, just let us know.
You do that, like implement that sort of training, like what you're saying on the cardiac arrest call.
Mm-hmm.
Just kind of run through that and see.
Yeah, we're going to do it a handful of times. So we'll run a couple of scenarios. And basically it'll be like Michael, pretend to be a police officer because, he loves the sheriff's department so much. So he'll pretend to be a police officer. He'll go in there, and then you'll come in with, your stuff, and then maybe CJ will show up as, showing up right behind y'all. So we'll work it a couple of different ways. Everybody knows that Mike's favorite place is sheriff's department.
Sure.
All right, so we started this case study. Eventually, I want to kind of talk to a couple of the doctors, especially the ones down in Renown, and kind of expand on this case study. But the big highlight for this was the interagency cooperation that we got out of everybody, from the sheriff's department getting on scene, us getting on scene, the hospital working with us the way that they did. And of course, I can't name any names, but he's not alive today if everything didn't go the way that it goes. Right? So we need to be like ultra clear at the fact that without the amount of cooperation that we got from top to bottom, he doesn't come back home. So we're going to run through this. I've kept this one pretty basic. Like I said, I'm going to expand on this. So there's a chance that this gets brought up later on down the road once we have, a little bit more expansion to it. I'd like to do this with the sheriff's department and possibly the hospital at some point. And then there's a chance that this goes in front of the hospital board to kind of push what Mikey was saying with the blood stuff. And, trying to get a better cooperation, logistically get a better cooperation. That way this can happen every time. And it's not just because everybody knows the person, right? So, little laggy. All right. So, all right. So we're going to look at the clinical presentation of the patient. We're going to identify some key treatment transport challenges. We're going to review and assess treatment response and outcomes. Reflect on the role of multi-agency cooperations, and then review favorable statistical outcome of pre-hospital. I don't know why I put all these goddamn big words in here like I can pronounce them, but we're going to freaking look at it and see how he turned out. All right. So the call comes out, right? We got a 27-year-old male with an accidental GSW to the abdomen. So again, the multi-agency cooperation, your life shouldn't have to depend on where you live. And that's been a quote in EMS for, I know as long as I've been here, is your chances of survival is directly correlated to where you live in this world. And I feel like we're past that in the world. There's so much technology and so much, stuff you can do for patients now that there's no reason why, even in these small rural communities, that we can't practice good medicine and get these people back home. It just doesn't make sense. And so if we can get good cooperations from the hospital, practice good medicine on our end, and then, get these folks where they need to go, being a big part of that is, we don't have to sit out here and let these folks die in Battle Mountains Hospital. So, all right. So the clinical presentation. So we got a 27-year-old male with a penetrating wound to the right upper quadrant, with an exit wound to the right upper flank. So the initial penetrating trauma started right here around this bottom rib and come out right down here around his back. All right. So we know there's a lot of stuff in there. Obviously, diaphragm, liver, intestine, like there's a lot of junk in there that can kill you real quick. So when we got there, he had a GCS 15. He was cool pale, diaphoretic. He had good pulses on initial contact. He had no breath sounds on the right side, and then he said that he couldn't exhale. So when we grabbed him, we tossed him on a mega mover pretty quick. And when we got him in the back of the truck, that was one of the first things that he said was that he can't exhale. So pay attention, right? So we know that this was an odd case because this person knew what was going on with them, right? This patient, clinically, and all the autism, is a lot smarter than a handful of us here, right? So he knows what's going on with him. But even if it's not him, listen to what your patient's saying. Don't just get tunnel vision going, oh, he's got a hole in his stomach, right? Listen to what they're saying and pay attention to what's going on around you, because that could be the difference on whether you let this patient die in the back of your ambulance. So, early recognition for treatments. So, we arrived at the patient at 9:27. At 9:30, we got our first set of vitals. Like I said, he was awake, talking to me, and he had a pulse. I'm not going to sit there and dick around with him on the couch and fumble dick with a monitor and all this crap, right? I know he's got a pulse. I know he's got a GCS 15. I need to get him out in my working environment, which is my truck, and start doing stuff, right? So we moved him.
Before arriving on scene, you did request aircraft.
Yeah, that's all in here too.
Yeah, oh, you okay?
Yeah. So this was the first set of vitals that we got. Don't take too much stock in that heart rate or that oxygen sat. His hands were pretty cold. He probably wasn't circulating super great to his peripherals. And honestly, that pulse ox might not have been on super great. So don't take too much stock in that. What we need to take stock in is this one. This is 2 minutes later. Right. So what do we see? Blood pressure's in the crap.
Positive shock index.
Heart rate's high. Right. His entitle, if you look right here, his entitle's 19. I like entitle. It can tell you so much about what you got going on. Right. So a couple of things with tension pneumothoraxes, their entitle is going to drop because they're not getting good gas exchange. Right. They're not taking good breaths. They have a decrease in cardiac output. And so these folks, their entitle is going to drop. On the flip side, he's shot, right? So he could also be bleeding. So those are both things. You go back to the previous slide where he says, I can't exhale. Those are things that you need to take into consideration, right? If we don't listen to the I can't exhale and we just take stock in the fact that he's got a bullet hole in him, and we're looking at a low blood pressure and a high heart rate, you can consider that a traumatic bleed because you can't see what's going on inside his stomach. You missed the pneumo, the tension pneumo, and he dies in your truck 2 minutes later because that's where he's headed. He's not headed anywhere but to Jesus, right? So pay attention to what's going on clinically, and don't get tunnel visioned on the bullet hole, right? You got to think about what all is in that region and what all it can hit. This was 5 minutes after his decompression. All right, so we have a perfusing blood pressure with a good map. We have a heart rate that's come down some. Obviously, he's still going to be compensating some, right? Because he's losing blood somewhere. So his heart rate's still going to be slightly elevated. But if you look at his entitle's back up to 30. What's a good entitle?
45.
All right, so his entitle's still a little low, right? But with blood loss, you also have a lower entitle. So one of the parameters behind blood products on the ambulance that we ran in Georgia was an entitle lower than 25 with known active bleeding, right? So that entitle means something in trauma patients. This means that he is losing gas exchange somewhere, right? So we got to be mindful of that. Continue to be mindful of that. So I know this is going to be Mike's favorite slide. So this is the lethal trauma diamond. It used to be the triangle, but they have changed it to a diamond. What did they add? Why? Why did they add hypocalcemia into this? If you look at every part of this, What is this?
Calcium ions.
What is this? Is there a place that doesn't show up on this or on this diamond? Right. So when you have a loss in blood, you have a loss in calcium. If you have a loss in calcium, the biggest one, right, is that bottom left one, which is what we're trying to do. We're trying to get his blood to stop freaking pouring out of his body. And without calcium, it's not going to stop, right? So you have a problem with your clotting factors, which is the biggest thing. And then, of course, so we're going to try to hit all of these things, right? So we'll go over all the medications that we used momentarily. But so when you start losing calcium, your body does what's with your pH. What happens to your pH when you start losing calcium? All right. So what does a low pH mean?
Metabolic acidosis.
So you're acidotic, right? So you're trying to avoid that also. So, and then hypothermia. We worked on the hypothermia thing.
I can bring it in if you need a little show.
If we had more than freaking blankets around here, we'd let everybody try it. But it was like a 5-minute fight between our two minions on how to open up this tinfoil blanket.
I think we need to turn that blanket into a sash
Yeah.
and say, I survived renown.
I think by the time this was done, all we got covered up was his knees and his nipples. But you know,
Got a long torso.
but we can laugh about it now. But that was a good clinical decision, right? Because that's a problem, right? If they're hypothermic, their body isn't going to metabolize right, and they're not clotting properly, right? So all of these things intertwine with the next one. But a big thing is calcium. When you start losing blood, you're losing calcium, and everything else goes out the window. Everything that you have just kind of gets screwed up, right? So we tried to make sure that we hit all these points. We gave him calcium, right? We gave him TXA to help with the coagulopathy. We covered up his nipples to help with the hypothermia, right? So these are all things that we did, right? We were all sweating in the back of an ambulance because we had the freaking heat on blast. Mike lost a hoodie in this call that he tossed over top of the patient to try to keep him warm, right? We don't want to flood these folks with cold fluids, right? Like this is all, and that's another thing. Do not flood these folks with freaking fluids. If their blood pressure is a little low, or their blood pressure is low due to bleeding, you giving them a liter, 2 liters of fluids is not going to help them. It screws up their acidosis. It has no calcium in it. It's going to make them hypothermic. So it screws up their coagulopathy. If you give these folks fluids, you're just going to kill them. And you might not kill them right in front of you, but you're going to kill them a day or two down the road, right? Don't do it. Just because it makes you feel good to get their blood pressure up a little bit, that's okay. Medicine's scary sometimes. It's all right for it to be scary. If they need blood, call for blood or stop here and get blood. Hopefully at some point we'll be able to get blood products a lot faster. And you can stop here and get them on your way to the airport. So don't do that. If you do, you will absolutely get her started and you will get a gnarly QA message. It probably won't even come by as a message. You'll get a meeting. She'll come in here on her day off and you will have a not so nice meeting. So don't do that. All right. So treatment plans. External bleeding control. So when the sheriff's department first got there, the first thing they did was pack his wound and hold direct pressure. It's hit or miss on what you read. Of course, the sheriff's department did what they knew how to do, right? So they did awesome. Doing something is better than doing nothing, right? For us, be careful packing anything from nipple to navel, right? On their back, and me and her actually did some research and study. If you have, a gunshot wound that's, through the abdomen and out the back, you can pack the back wound, but because your abdomen is just so deep and hollow, you sit there and you just put galls and galls and galls and galls and galls and just be packing stuff in their stomach forever, right? So They did awesome. They were holding external pressure when they got there. They threw some quick clot in there, so they did great. The fact that they did anything is amazing, right? So, but for us, again, just be mindful of that. If you go to pack wounds, nipple to navel, occlusive dressings before you start packing stuff. Again, this calcium thing comes up, right? We have to give these patients calcium if they're losing blood. They're losing blood, they're losing calcium, their body's not clotting, right? Their pH is going down, they're getting acidotic, they're not clotting. So we have to replenish that. Even if you don't have the benefit of getting blood products, you can still give this calcium. If you do have the benefit of giving these blood products, you have to give them calcium. Those blood products come in a preservative that does not hold calcium products in them. They pull the calcium out of them. And so when they are calcium depleted, whenever we give them to patients. So if you give them units of blood, give them calcium. If we get a transfer, and we've had to do this a couple of times now, if we get a transfer and there's units of blood hung on that patient and they have not received calcium, call the receiving facility and get permission to give them calcium. We can do it anyway, but I just like to call them just to put a doctor's name on the thing since we're going from doctor to doctor, and they haven't denied me yet. So if you get blood products, make sure you give calcium. So the decompression. This is ultimately what would have killed him the fastest if we don't perform this decompression. If we don't catch this pneumo when we catch it, he goes into shock, or he's in shock, and he just continues to decompensate to the point that he goes, right? Pain management. Listen, I get that it's not your pain, and I get that you have a lot going on, but these people don't need to remember what's going on with them. Put them to sleep. So when we first got him in the back of the ambulance, Becca shot him in the butt with 50 ketamine. Unfortunately, we had to decompress him before we could knock him down. So I had to sit over here and make eye contact with him the whole time that needle was being shoved in his chest. That's not fun, right? We didn't have time to wait though. When you do have time, when you can take 30 seconds, give them some more pain meds. We ended up giving him 250 ketamine, and he took the best nap that he ever did, along with seeing some kind of weird cartoon characters. He loved it, right? And he doesn't remember anything else, which is the most important thing, because this is a traumatic event and you don't want to remember more than you have to. Same thing with the call where the guy broke all the ribs, down here over the weekend, where we were in rescue 4. I knocked him down as soon as I got a chance with a bunch of ketamine, right? So put these folks to sleep. Don't be scared of it. It's all right. If you got to bag them a little bit, that's cool. Bag them for a minute. But if they're asleep, not only are they not fighting you, which is going to make everything that they have going on worse, right? Because their body's in this excited state. So it's just going to make everything worse. But on the biggest thing is they don't remember what's going on. And so that benefits them drastically. Mentally, it benefits them. We're not just thinking about the physical aspects, but the mental aspects of it too. TXA, don't forget this. Again, this is a hit or miss drug, right? Some doctors you talk to absolutely live by TXA. Some of them you talk to don't think it does anything. We have it, use it. We use 2 grams of TXA on him. Put it in a bag, let it drip. The military's just pushing TXA now. So if you draw it up and want to push it, you can draw it up and push it. Either way, they need it, give it to them, right? We have it. There's no point in not using it, right? If there is some benefit to it, just try to get it in and use it.
When we delivered, it was in a 100 ml bag.
Yeah. So we took. Oh, go ahead.
I was just gonna say there are studies where they were like, they did the studies with the TXA in the hospital, and they're like, oh, this isn't any benefit. So they were trying to get it out of pre-hospital, and then someone came along and was like, hey, let's actually do a study pre-hospitally with this TXA, and it significantly reduces mortality. So
yeah,
it's interesting.
Yeah. So be mindful of that. Make sure that you can get it. So we did 2 grams in a 100 bag. there's, again, you can push this stuff, so there's no real formula on it. You know, put it in, take 2 grams, shoot it up in a 100 cc bag, hook it into a line, and let it run. You don't have to do like 2 drops per every 3 seconds. No, turn that bastard on and let it go. Respiratory compromise. So with this particular patient, we had a couple of different issues, right? So after the initial sedation, he had he had periods of apnea. His respiratory system dropped on him. He had almost, I mean, at one point he wasn't breathing at all, and we were bagging him. We noticed it. We noticed the desaturation. We noticed the respiratory drive dropping, and we were able to catch it pretty quick, start bagging him. We stuck an MPA in him because he was a little bit harder to bag. And then we bagged him for probably 5 minutes.
It felt like 45.
Yeah, it wasn't very long. And then he started breathing on his own again, and everything was fine. Breathe him through that period, bag him through that period if you have to. But that doesn't mean that you have to be, that doesn't mean that you have to be scared of giving it. Just be mindful that when you do give it, there might be a chance that this happens. To piggyback on this, I didn't think that I pushed the ketamine super fast, but apparently I did. He did have a period of like hypersalivation. So make sure you're suctioning his airway when stuff like that happens, because you don't want him to aspirate that stuff and end up, more sick later on down the road because of the aspiration. So be mindful of that. Pay attention to what your patient has going on, because again, that's one of the side effects, right? A way to kind of mitigate that issue is just give it IM. So we were listening to a podcast about a month ago where the guy was talking about RSI, and he said the first thing he does whenever he's getting ready to RSI somebody is step up in the truck and slap him in the leg with 300 milligrams of ketamine. And that's the first thing he does, because it takes away that excitement factor, and so it just slow pushes itself, right? Because it has metabolized into your body. And so a way to mitigate that, the potential of being all excited and worked up and pushing a little bit too fast, and you have the respiratory compromises, is slap it in their leg. Draw up double what you were going to and just put it in their leg, and then let it self metabolize, and then, knock them down like that. So blood administration. Again, the hospital was the biggest asset for this whole process, because initially we thought we had blood, and then we didn't have blood, and then we're all sitting on the airport with our peckers in our hands trying to figure out what our next step was going to be. Mike was, awesome on the back end of making a bunch of phone calls and, making this happen, right? There was 2 units of blood in him by the time we left that hospital and got back over to the airport. By the time we were loading him onto the airplane, he had almost 2 full units of blood, and we actually sent him with 2 more for the flight crew to initiate on the way to the hospital. So we took all of their, what was it, O-neg? We took all of it. It was ours. So that was a benefit. Again, logistically, this is going to be, it really just depends, right? Lucky for us, we had a good doctor there that day that was working with us and was giving us everything we needed. But again, it just logistically right now it's kind of difficult, but we're hoping that that's going to get better. And then the big boy, the late great Ansef, that has been fighting infections in this poor kid's body for the last 2.5 weeks. So we don't carry it. We were able to get it from the hospital. Again, it's patient dependent. So my old protocols were a gram under 70 kilos and 2 grams over 70 kilos. Ansef comes in a powder that you just reconstitute like Solu-Medrol, except it doesn't have a little ball that you push in, and it's all fun. This stuff is messy. It's like freaking paste. But hopefully we're going to have it soon. Probably this next year, we're looking at trying to build a protocol and put this on the ambulance. So be mindful of that if we do get it. But ANSEF is not for us. It's for the patient later. So again, this is just like Solumedrol on a breathing call. The Solumedrol is not for us. It's for an hour, 2 hours, 3 hours later to try to keep that patient breathing good. The ANSEF is the same thing. The ANSEF is not going to have any clinical benefits for that patient in the moment that we give it. But anytime that you have a patient that has any sort of outside object that has entered their body, any sort of significant trauma that looks, you get somebody that rolls a full wheeler over and, they got a bunch of dirt and nasty and gnarly all in their arms, right? Like they need to get this ANSEF because they're going to get it. They need antibiotics. They have stuff outside their body that's going inside their body and their body's not going to like it very much. So we need to give these patients antibiotics. All right, some considerations for treatment and transport. So we're 3 hours from the closest trauma center. Sucks to suck. I don't know what to tell you. That doesn't change the outcome of your patient. If you take them to your local hospital, they can't do anything for them, right? Like you need to try to stabilize these folks as much as you can and get them out of here. Because we can give them all the blood that they have in that hospital, but unless you can stop what is bleeding, it's not going to benefit him, right? And, me and Mike had this after I was a little heated one day. We had this talk, and I walked in there and cut a bunch of holes in a Coke bottle, and I handed it to him. I said, when you can fill that up, come let me know. Because at the end of the day, you can pour fluids in somebody all you want to, but unless you can plug those holes that the fluid's pouring out of, you're not doing them any benefit. And they're not going to open this kid's stomach up and start plugging holes in here. He needs to get somewhere else. And so that's where he's going to be most beneficial at. Get them stabilized and get them where they need to go. So at 9:27, if you remember, that's what time we got on scene, right? When we got the call, me and 80 were sitting at this hospital over here just kind of bull crapping. When we got the call, I looked at the doctor and was like, hey, I'm going to fly him. Don't worry, I'm not coming over here. He laughed and said, okay. All right. I walked out of that hospital. The second my butt hit that ambulance, I got on the radio and said, hey, I'm en route. Go ahead and launch Reach. I called Reach because they're supposed to have blood products, right? So that was my first go-to was the blood products because you got a gunshot, I need blood. At 9:27, they got on the radio and said blood products were en route with the flight crew. At 9:34, we were able to get him out to the ambulance and do the recognize this tension pneumo going on and decompress him. At 9:38, we left scene. So we were on scene for approximately 9 minutes. And we bypassed the hospital and went straight to the airport. At 9:40, they called back on the radio and told us that they didn't have blood products available and that they were now where that line of communication failed, we don't know. Apparently the blood products were expired, and so they didn't have any available. Where the line fell and how it was communicated that they were coming and not coming, we don't know. You take your hits where you take them, and you try to figure out a solution for them. But that means we had patient contact for 13 minutes prior to understanding that he didn't. We were sitting on the tarmac at the airport when this call came over the radio. CJ had gotten out of the ambulance, and the second he stepped up in the back of the truck, dispatch started calling us. And I told CJ they were trying to call us. He got back out of the truck, walked over there, and they said, hey, they ain't got blood. So figure it out. At 10:05, we were able to give him blood products from this hospital. So 25 minutes later, we left that airport. Mike made a bunch of phone calls. We left that airport over there. We drove over here, and he had blood products 25 minutes after we found out that none were coming. And he needed them. And we knew he needed them, but we also knew that he couldn't sit at this hospital because it wasn't going to benefit him. At 10:31 is when we arrived back at the airport and the flight crew was on the ground. So, if I'm not mistaken, I think the flight crew arrived,
9 minutes.
was it 9 minutes before we got there?
Yeah.
So they can hang out, right? Because by the time they land and they get all their crap shut off and get all set up, right? Like they were probably only standing around for, 3 or 4 minutes by the time that we got there. So there was really no delay in his transport time, considering what he needed. Turn the page. So this is our little timeline breakdown. So the initial dispatch come out at 9:18. The sheriff's department was on scene 1 minute later. Smith was hightailing it. Smith was the first one on scene. The patient was withered enough to tell dispatch his door code. He walked out to the living room and sat down on a couch and waited. But it was 1 minute from the time that we were dispatched to the time the sheriff's department was on scene. We were on scene in 9 minutes. So our initial process, right? We get out of here, and we're thinking that we're staging for PD for a few minutes. So we're not flying down the road until we realize that it's an accidental gunshot. And when it's fine. You don't stage for PD. Well, I don't stage for PD, but don't do that. I do sketchy things, which causes Mike a lot of paperwork, and we just don't do what I do. So 7 minutes after we arrived on scene, he was decompressed, which is pretty good, right? There's scenarios where you walk up and you immediately decompress the patient, but like I said, when he decompensated fast. You saw his first set of blood pressure and his second set 2 minutes later, so he decompensated fast. And so as soon as he decompensated, that second blood pressure was taken at 9:32. 2 minutes later, he was decompressed. The blood administration was 30 minutes later. And then he took off 30 minutes after that. So the entirety of this call took us just over an hour. Right? It's easy to, scoop a patient up, be on scene for 5 minutes, throw them in the back of the ambulance, run them over here to the hospital as fast as you can, dump them on one of their beds, and then just wait on a transfer call. But that's not what they need, because now they're delayed at this whole process took an hour. If they get over here, now he's 2 or 3 hours, right? And now he dies over here at this hospital, and that's not what he needs. He needs to go to a trauma center. Don't be scared of medicine. It's okay. It don't bite most of the time. So treat these patients. Try to stabilize these patients. Get them where they need to go, not where you feel comfy. I know it's scary. It's all right to be uncomfortable. They need to get down to that trauma center. Make sure they get there, and make sure they get there alive. All right. Go away. All right. So, again, this was that blood pressure 2 minutes after we took the first one, right? This is when he left. That is beautiful.
It's better than one.
That is gorgeous, right? And so his entitle was back up. So he had like a little bit of a drop in entitle right before we gave the blood. His entitle was sitting in like the low 20s for a minute. We started administering blood products, got his entitle back up. We had him on a nasal cannula, and that was just because we had him on entitle, so we just bumped him on a little bit of oxygen. His heart rate is beautiful. His blood pressure is beautiful, right? So now we have taken most of his compensatory mechanisms and fixed them. We've given him the blood products. We fixed his airway issues. So now his body isn't compensating nearly as much as it was. Now his body's just pissed off because it's got a big old hole in it. But he's not losing a bunch of blood. He's not struggling to breathe, and you can see that. You see what happens whenever you make good clinical decisions, how your patient leaves you, and that's what you want. You want your patient to leave you in better condition in which you found them, which is what our end goal, and that's what we did. So, some key challenges. This is the hardest one by far, right? I think we all know that. There's no sugarcoating it. There's no way to wrap it up. It sucks. You live in a small town. You know every goddamn body. It's not a matter of if. It's a matter of when you run a call on one of your friends or your family. There's no way to sugarcoat that, and there's no way to mentally prepare for that. I've been doing this for almost a decade, and so has she. I've ran every crackhead and gangbanger in Atlanta with a bullet hole in them and didn't care, right? I didn't think about them after I left. We did our job. We dropped them off at the hospital, and we went on about our business and ran another call. This is not one of those calls. Mentally, it absolutely tears you up. And so the hardest part for us was trying to make clinical decisions in the back of the truck without second guessing ourselves. And one of the biggest things here, I know I've been asked this question 100 times in the last 3 weeks, and I'm sure Becca's heard it a handful of times in the last 3 weeks, is how me and her can operate in those conditions the way that we did. And this goes back to the training aspect of autopilot. We have done it so many times at this point that all the decisions that we made were just autopilot. And so at a certain point, you get away from the mental game and you just fall into what you know how to do, which is what happened, right? God knows that y'all have known this kid for 10 years, right? Especially Mike, 80, Marcus. You've known him for 10 years. It's hard. It's rough on you. Mentally, it's a battle because you second guess yourself. And me and Becca, we got him over here to this hospital and we were walking him through the halls and I pulled Becca to the side and we had a conversation like, what else do we do? We've done X, Y, Z. What else needs to be done? We've done this 100 times. Like we're second guessing ourselves because of who it is. What else can we do? And the only thing we could come up with was blood and NSAID. So you do everything you can and you hope for the best. But that's the hardest part of this call. Second hardest part of this call is the fact that he knew what was going on with him. So at one point, he looked at Mike and started naming all phone numbers and names and saying, I need you to call these people and tell them I love them. He knew he was dying. That's hard. That's hard on you mentally because at that point, you know that you have to make all the decisions to make sure that doesn't happen. Clinically, you just do the best that you can. And at that point, it's between him and the Lord as to what happens. So that's a really hard one. The capabilities of this ER over here, again, we can do everything in the world for him, but unless the bleeding stops, eventually they're going to run out of blood. They're not a blood bank. They don't have all the units of blood in the world, and eventually they run out. He continues to bleed, and he dies on that hospital bed. Right? Excuse me. There's an extended ETA to a surgeon, which is what he needs. He needs surgery. There's no two ways about it. He needs somebody to go in there. He needs somebody to stop that bleeding. This was a big one for us because at that point we have to make a decision. We have to make the decision to either take the chance of letting him sit in this hospital or take the chance of putting him on that airplane and hope that he makes it to where he's going. And that's a decision that you just have to make and hope for the best. Again, we had an amazing cooperation from this hospital, and that's the reason why we can make both of those decisions. We made the decision to come over here and get those blood products, and we made the decision to put him on an airplane and get him out of here. And without them cooperating with us, at that point, you have to make a really hard decision. Because does he make it to Reno without those blood products? Or does he sit over here and die in this hospital just being flooded with them? And that's a decision that we didn't have to make, luckily. But if you're ever put in that position and you don't have that cooperation, which is what we want, that's a decision that you're going to have to make. And it's not an easy one. Because me and Mike were sitting there having that conversation about what we were going to do next if we couldn't get blood products. What was our next move? Are we going to take the chance of taking him over here and starting him on blood products and hoping we can get a transfer out of here quick enough? Or do we take the chance of putting him on that airplane and hope he makes it to where he's going? So that's a really hard decision to make. And again, communication and cooperation with the local ER. Mike did fantastic. Mike called them. He laid down what he needed. He told them the parameters behind what he was going to get if he was coming. He told them flat out, like, I will come over there. I will get these blood products as long as you promise me he don't leave my stretcher and we can turn around and walk back out those doors. Again, that's a decision that Mike did fantastic working that process. And the hospital did fantastic in allowing us to do that. Because without that cooperation, there's no telling where this call goes from there. So, the recognition of respiratory compromise after sedation, again, just because these folks go to sleep, you still have to pay attention to them, right? So pay attention to what your patient's doing post-sedation as well as pre-sedation. A lot of these sedation meds that we have, even though ketamine is statistically is the less aggressive of the group when it comes to sedation, with like the hemodynamic instabilities, you still have to be mindful that these are still problems that can arise, and so you got to pay attention to what your patient's doing. So this is the conclusion that I've come up with. So this call shows fantastic agency cooperation across the board from start to finish. No single decision that was made on this call was his saving grace, but collaboratively, all the decisions made are the reason why he had a positive outcome. We are extremely grateful for the Sheriff's Department and hospital staff that we worked closely with to ensure happy endings for a great friend. You do not have to have a poor outcome because of where you live. Less than 2 weeks later, this patient's getting ready for his final days in the hospital. Again, this is absolutely, and it drives me nuts. Becca's had this conversation with folks since she's been out here, not here, and the land and the shadows in which we don't talk about. Had conversations with folks about, we're not 20 minutes from a trauma center, so we have to do this or we have to do that. You don't have to do anything. You don't have to kill your patients just because you're not 20 minutes from a hospital or 20 minutes from a trauma center. You treat your patients appropriately. You get good cooperation across the board, and you have positive outcomes for your people, because that's what we're here for. We're here for patients. We're here to treat these people properly. We're here not to be scared of medicine, because that's what we do. That's what we're paid to do. When people call for help, we're the ones that show up, and your job is to be confident about what you're doing, be thorough with your abilities, and train, educate yourself, listen to podcasts. I don't know how many times me and Becca's going on freaking road trips, and we've listened to freaking medical podcasts for 3 hours. Listen to these things. Pay attention to them.
EMS 2020 is my favorite.
EMS 2020, Foam Frat, freaking, what's the other chick's name?
Medic mindset.
Medic Mindset.
We got this if anyone has questions.
I mean, they're great, but listen to them. It's retention, repetitive, retention, and then you go into autopilot. Every single person from top to bottom did great on this call. Mike did great. 80 did great, right? The hospital did great. The Sheriff's Department did great. But me and Becca has been asked 100 times how we functioned, knowing the severity of this call, and all it boiled down to was a repetitive retention autopilot. If you repeat yourself, you train on it, eventually your hands just do things without you thinking about it. And so you have to be mindful of that, right? Don't be scared of medicine. Be scared of your lack of knowledge of medicine. That's the only thing that's scary about this, is when you run these calls, you need to know what you're doing, because that's what you're paid to do. If you show up and fumble dick your way through calls and you kill the crap out of somebody, I promise you will go home that night and lose sleep over it. I have made clinical decisions in the last decade that maybe have not been the best for that patient, and I have second guessed myself a million times over it. But I took the call, I learned from it, I trained on it, I researched it, and the next time that call approached, I didn't make that same mistake twice. You're going to make mistakes, but you have to recognize what's going on with these folks, because you don't want to go home on your conscience and run this call, and this call goes south, and then you go home with that on your conscience. Be good at what you do. That's the biggest thing that I can take away from this call, is be good at what you do, train hard, because I get that we're not dealing with gunshots every day, right? Me and Becca's been on the two that's happened in the last year, right? So you're not going to run these calls every single day. But at a certain point, you run into autopilot. Me and Mike sat down and talked about it the other day, right? When he goes to do an RSI, he does his RSI the same way every single time. It's because that's how he trained, that's how he learned, and he trained and he learned, and now every time he goes into that RSI, he autopilots, and he does it the same exact way every single time. And so when you're running these calls, train yourself to a point that you autopilot through them, and then you don't have to think about it. You just do it. So that's my little spiel. Anybody got any questions? What questions do you have for me? Is that what he said?
Can you real quick touch on optimal sites for needle decompression and kind of what the trigger point should be for a needle decompression?
So a couple of things that I think of when I think of needle decompressions: penetrating trauma is one of the big ones, and blunt trauma to the chest. The last needle decompression that we did was a blunt trauma in a car accident, right? And so some people still talk about the mid-clavicular, freaking needle decompression. Don't do that bull crap. Just don't. All right. So with the mid-axillary, does everybody know how to find this landmark pretty quick? The diamond works good. Mike's talked about the diamond. So if Becca wants to come over here, she can show you how, and this is a you and your partner thing, but it keeps your hands free, right? So whenever you go in for this site,
Or put their arm up.
Yeah.
Hand up in their armpit, and then you just grab. So this helps for multiple reasons, because if they're fluffier, or like one of our ladies had a flat boob, so she had a lot of adipose and just tissue here. So once you do this, you grab, and right where your little pinky sits is where you want to go.
you're almost in their armpit, right? This is how big your lungs are. If you actually look at like diagrams of your lungs, even like this little guy in here, your lung only goes to like right here. People think your lungs are way down here and all this. You're not out here trying to do liver biopsies, right? Why do we pick this site over the midclavicular site? Just, there's no real wrong answers, but I have a couple of really nice answers that I like. Anybody?
Also a chance to hit a vital organ.
Yeah. So you have up
Those
here.
lumps right here. So if you're going in here, you look at these needle decompression needles, and the ones that we just got, the spears, they are this long, right? So if I hold this pen up to my chest, what sits right here at the end of that needle?
Apex.
little heart, right? So whenever you come in, obviously you're not sticking the needle all the way in, but you lessen your chance of going here. But if you go here, how close are you to that?
Like you take her arm and you stick it up right here, right? Look how far that needle would go into her chest. That almost, I can almost push that thing out of the back, right? So that's one big thing. Another big thing is if you have fluid, where does fluid settle? At the lowest point, right? And when you needle decompress these folks, how are they laying? They're laying on their back, right? So if they have a hemopneumo and they're laying on their back and you poke them right here, you're pushing that blood out as well, right? Because they're laying on that back, all that blood goes down, and you poke them right here, and now that blood's coming out. And I know some people are like, oh, well, you're not supposed to decompress hemopneumos. Well, if you've got blood around their lungs that's, making it hard for their lung to expand, that crap needs to get out too. And so when you needle decompress them right here, you're losing the air and you're losing that fluid. And so it pushes all that stuff out too. So be mindful of that. Again, I mean, even me, I'm bigger than she is, but you stick that needle in and you're still, you're way back here. You're almost at my back. So that's one big thing is when we start dealing with these spears, be mindful of that. So do we have?
We're gonna do training on the spears too, because we just got them in, so everyone can put their hands on them. Everybody.
Yeah.
Do we have that one here, or is it in my car? Either way, they're big.
They are really big. Can you pull up a picture of the spear on that computer in there and share it in here, CJ?
On the shelf.
Just don't open it. It's just that's it. Mike might yell at us.
Fiscally responsible.
Fiscally responsible.
While we have lag time. Look at that jawline. Look at that lag time. Look at that jawline.
So pause it right there, CJ, or wherever we can see the needle. All right, right there. So this is what we're using right now, right? This thing is freaking dinky. And I only know it's dinky because we just used that bastard. It is dinky. But you see the size comparison of those two? It's a lot lighter. So whenever we do these decompressions, what you're going to do is you're going to take your finger and you're going to find that rib, right? Bloop, 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 bam, rib, found rib. And you're going to run your finger all the way down to their skin. And then they have these little marks on here, these little centimeter marks. And so if you hit rib and your finger's sitting right there on this mark. Oh. Yeah, there we go. So if your finger's sitting right on this mark, you're going to back it up 3 little dots. You're going to go above or below the rib. All right, so we're going to go above the rib line. Yeah. There's vessels underneath, there's nerves, there's blood vessels, all kinds of junk that we don't want to go poking with a big old fat, what is that, like a 14 gauge needle?
I think they're bigger than 14.
They're freaking huge.
I think it says it might be 10 gauge.
Yeah, them things are freaking huge. But anyway, you don't want to go poking. So what you're going to do, you're going to back your finger up 3 little dots and you're going to run your finger back into their skin. When you run your finger back into their skin, you're going to hold your finger. So if you hit rib and your finger up against their skin is sitting on this line, you back it up 3 and then you run it back into their skin. And once you run it back into their skin, you're where you need to be, right? Because the person's size doesn't change between their ribs and lungs. They only get fluffy outside their ribs, right? There are some extenuating circumstances to that where you have to, like, broken ribs and stuff, be mindful of all that stuff whenever you go poking around. But you go in there, you find your spot and you feed it on just like the old ones. And these have a whistle valve in them that you can attach to the top of them. And while air is escaping, you can actually hear it because it'll send out this little tiny whistle. And then they have a one-way valve on them, so they let air in or let air out, but won't let air back in. So they're pretty nice.
And they also have little like fenestrations, so there's extra holes in the actual catheter part that you're feeding into their chest. So if they are bleeding or if anything gets kinked, then it allows more air to get out rather than just the tip. It's gonna be tip to tip. And it's gonna be all the way around.
Yeah. So there's little holes. I think it's like every 2 lines. There's like little holes that run up that catheter. Yeah. It's on it. Yeah, see, that thing's freaking huge. You don't want to go poking stuff you ain't got no business poking with. So,
If you do the needle decompression and it starts pulsing, call somebody.
yeah,
It's a bad day.
yeah, that's not good. Another one. Did we really have any points of failure with this call?
I think our biggest point of, nothing actually failed. I think our biggest point was probably just that we expected one thing, and halfway through that, right, the blood was not there for us. So just making that last minute decision and that informed decision of, what are we going to do now? And I think that goes back to, right, you have your plan A, but you better be ready for plan C, B, C, and D in case something changes, right? What do we do if that needle decompression doesn't work, right? What's after that? What do we do now that that blood product's not available? How do we optimize care going forward from there? Are we going to potentially have to RSI him?
That's one point of failure that I did find is Mike was standing in the back of the truck with ET tube and stylet and all this stuff, and I was like, no, we're not doing that. And I said that out loud, and Mike knew that we weren't doing it right then, right? But I was like, we're not wishing that on him. We're not doing it. That was a failure on my end because even though I didn't want to do that, we should have prepared for the necessary for the need had it arisen, right? So when you got free time, especially for us, we had 4 people in the back of the truck. And there's actually something else that I'm working on the outside. One of my old bosses from Georgia, he's a programmer and does a lot of IT stuff. And he's trying to write a script for us to have an RSI calculator, where basically all we'll have to do is put in a patient's weight and it'll calculate all of our drugs for us. So again, I'm a huge fan of cognitive like overload and like not getting to the point of cognitive overload. So if there's some things that we can kind of push off and we don't have to think about, like a RSI calculator, I love it. I think it's fantastic. I think it's the best thing in the world. And I'm a huge proponent of it. So I'm working on that, but that was absolutely a failure on my end. Was I should have prepared for that had it arisen, because had it gotten to the point that we needed to RSI him, we had no dosing calculations ready. We didn't know, how much of these meds. They were all still locked up in the cabinet. Like we didn't know any of that, right? And that was on me because I told Mike to frick off when he was pulling all the stuff off, and I shouldn't have done that. We should have prepared for that. So, like Mike said, you're hoping for plan A, but they don't work.
Okay, so with that being said, what would be optimal treatment if the blood products would not have been available?
So it's hard, right? And we discussed that. So hemodynamically, he was pretty stable. Even before the blood products, I think the last blood pressure we got right before we started blood products was like, it was soft. It was like right around 110s. I think he still had a map right around 65, 70. It's really hard to say what the right call is at that point. clinically, you know that where he needs to be, and clinically, you know that he has no benefit from sitting at this hospital for 2 or 3 hours without a surgeon, because that's what he needs more than anything. So
That's definitely agreeable. But more, we've been taught always, that fluid, and it is shown that fluid overload is bad, but it's still part of that protocol to start dumping NS and for that blood pressure side of things.
So, yeah, Alan, you're right. About 10 years ago, now fluid resuscitation is completely out of our protocol. We are shooting for a MAP of 60 to 65. And I would actually say that I would almost rather see a low dose vasopressor in the event that you are that peri-arrest before we start dumping fluids into somebody, because it's a facade, right? Fluid, it's low on the pH scale, so you're driving their pH down. It doesn't carry hemoglobin. It doesn't carry anything that's going to promote the clotting cascade. So the most recent studies actually show that if you give these people patience, you are aiding in their mortality. So I would actually go opposite of that and do a low dose vasopressor. Now, if you're an advanced EMT, right, and you don't have the option for a low dose vasopressor, then, and you absolutely have no other options, I'm going to tell you, let that blood pressure go as low as you can absolutely take it. And if you're going to give them anything, you're going to give them warm lactated ringers in small aliquots, which is going to be 50 to 100 mLs at a time. And you are going to do it slow. You are going to do it warm, and you're going to reassess every 2 minutes. And that is going to be your best bet. So I don't know if you guys know this, the pH balance of normal saline is in the 6s, and the pH balance of lactated ringers is in the high 6s. So it's just trash. It's not good. I know Elko County still has it in their protocols. I think Dr. Milligan's probably going to gut that as soon as possible. But yeah, giving fluids to trauma patients, it's to make your number feel better, and it's to make you feel better, but it actually increases their mortality over time. Like I said, if you have zero other options and their pressures are like 40/20, sure, do that. Us here, I would rather see you start a vasopressor before you do that.
So me and Beck
Perfect. That's what I was looking for.
Yeah, so me and Beck actually, so I know that you'll be here Saturday, and we'll kind of leave this out. There's a little thing. I say me and Becca kind of rage research is what she calls it. We had a conversation that didn't really bode well with us. And so Becca started rage researching. And part of this is basically saying that any use of crystalloid solutions in trauma patients is bad. It increases mortality rate, whether you're giving them 1.5 liters or 500 mLs. Any use of crystalloids in trauma patients is going to bode is bad. No go, right? Again, like Mike said, you're making them acidotic, you're making them hypothermic. You're absolutely destroying any chance they had of clotting, and so that's a big thing. But they did say that one of the big treatments for this is norepi. And so if you have a patient that is trending on the lower side and they're getting peri-arrest, to do a norepi drip before flooding them with fluids. Again, you're looking to get a decent perfusing pressure, but permissive hypotension in trauma patients it's fine. It's not. I know it's scary, and they actually did. So Medic Mindset did a kind of it was like an in class study where she took patients and like tossed a heart rate out there just to see like who was uncomfy and would start treating that heart rate. no symptoms, no anything, right? Would just see like, okay, well, let's see what number's scary for patients. And Becca's had one where her heart rate was in the 30s. She was non-symptomatic. She had no complaints. Her daughter called because she realized she was checking her vitals that night and realized that her freaking heart rate was in the 30s. But like the patient and Becca will tell you firsthand, like she was not comfy, but she didn't do anything, right? And these trauma patients, huh?
I still started when I did, and put the pads on just in case, but I didn't do anything.
Yeah, she didn't, but that's uncomfy, right? Like you see somebody's heart rate at 30, like you want to do things. You're like, I have to do things. Same thing with overdoses. You see somebody and you're like, oh, they're overdosing. Are they? But they're breathing. Do you have to do things? So same thing with these trauma patients. Like their blood pressure a little soft, a little scary. Where's that number get scary for you, right? And so that's what you have to be mindful of. Is like just because it's scary to look at doesn't mean that it's terrible and it's going to be the end of their life. I'm gonna be honest with you, and I'm gonna stand 10 toes on this. Had we had to make the same decision and the hospital didn't allow us blood products, I still would have put him on that airplane. Clinically, I'm hemodynamically, I feel like he's stable enough to make it to Reno.
And we also thought, like, our plan of attack, and we talked about it as a group, was that if he did start declining again, our next step would not have been like fluids or anything, it would have been to decompress again. Because you always have a chance for that initial decompression to clot up, like we were talking about, or bend or kink off. So that was gonna be our next plan of attack, like, yeah, his blood pressure's going back, well, let's try this first.
Yeah.
But that's always a possibility too, that you needle decompress multiple times while they're in your care.
Yep. So just because you fixed it one time doesn't mean that it's the end all be all. You might have to do it again. So keep all those things in mind. Again, I don't. He got the best chance he was going to get coming out of Battle Mountain. That's just twofold, and that's just the way it goes, right? Like you don't get a better cooperation from everybody involved than you do on this call, from top to bottom. But and logistically, people aren't going to see a lot of what Mike does, but Mike's working pretty hard to make sure that every patient that we have that's like this gets the same treatment. He wants every patient to get the same treatment he got. I actually asked permission before talking about this call with everybody to make sure he was cool with me building this PowerPoint. And he said if anybody could take any information and learn from it, he was 100% down. And so he's the one that gave us permission to do this PowerPoint, to kind of work off this case study. And so don't, and I say this as nicely as I can, don't be incompetent for the Calvins in the world. Just don't, right? Because if you're incompetent just from lack of training, from, being complacent, and you aren't competent enough to treat these patients, you kill them. And then you have to go home and sleep with that. I don't. But, be competent in going into these calls. That way you feel good whenever you get done with it, right? You feel good about what you did on the call whenever you get done with it, because you don't want to be, killing somebody and then second guess every decision that you make, because that's not going to end well for your mental health. I promise you, it's just not. I don't care how tough you think you are. You kill somebody, and you know that your clinical decisions are what led to that death. You're done. You will, on top of the fact that you're probably going to look at some pretty fat lawsuits, mentally you'll be out of this for a while. So
Be mindful, you can always phone a friend. So like, Chaz and I called Mike the other day on a transfer. Like sometimes you just gotta work things out in your head, and sometimes it helps you to work it out when you're chatting out loud, and maybe they have more info to give you than what you can come up with. So just be mindful. Like I know Chaz and I are always open. Mikey's said he's always open for a phone call. I don't want to throw you in the bus.
No, 24/7, man. That's what they pay me for, right? You're in a spot where you need to chat or you need a little advice. Like you can call me and we will work through the call together over the phone, 100%. And to be as open as possible, right? You guys call me. I have called people plenty of times, right? Mike and Dana, every time I get a tough vet patient, I get about 10 minutes into it. Shit's not going my way. I start running out of ideas. Dana, good morning. It's 2 a.m. Thank you for answering my phone call. This is what I have. Right? Like we are all in this together. So 100%, man.
CJ will tell you, one of the first like bad calls that we ran together was that girl that got hit by the car over here. And I was trying to figure out how much ketamine I could give her before I knocked her down a no-go zone, because I'd already given her some, and I was trying to figure out if I had waited enough time to give her more, and I was just drawing a blank, and I called her. There's nothing against calling somebody to ask for help when you need it. There's everything against knowing that you're in above your head and not making those phone calls. On the flip side, back to what Mike said earlier during the initial meeting, when it comes to like after call reviews or after call help, or he says that there was a handful of people that said that they would like to see more of their calls, kind of talk through or walk through. I am 100% putting that on y'all. I don't. Mike can feel, or say his two cents if he needs to, but I am 100% putting that on y'all. Me and Becca do QAs. If there's ever a call that you run and you're not super comfy with it, I don't know that you're not comfy with it unless you come to me and tell me. If I was up here after every call that somebody ran, making sure that they felt good about the call they ran, I'd be up here more than I already am. And I'm already up here almost every day. And so if there's ever a call that you run and you're not comfy with how it went, pick up the phone and call me or her. I mean, we will be more than happy to come down here and talk to y'all about it. Run through the call, run through a scenario with the call, run through the chart, whatever you need to feel better about it. Whether it's just reassurance that you did fine on the call, or whether it's, decisions that you made that you aren't super comfy with, but need to know whether they were right or wrong. But that falls back on the providers, not us. I can't go behind every single call, and Becca's not going to go behind every single call and make sure that you felt good about the call. So if you don't feel good about it, call us. So that has to be put back on the provider at some level, just because I can't check in after every single 911 call to make sure you felt good about how it went. So, yeah.
Any questions? Okay, are we good to break this meeting then? Okay. All right, guys. Thank you.